This podcast is being recorded on the lands of the Wurundjeri and the Bunurong people of the Kulin Nation. We pay our respect to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders, past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest clinical guidelines and research in obstetrics and gynecology through conversations with leading experts. TORCH serology encompasses Toxoplasma, rubella, cytomegalovirus or CMV, and herpes simplex virus or HSV. These infections can cause transplacental infections and severe perinatal mortality and morbidity, and congenital infection may be associated with fetal growth restriction or FGR. Today we'll be discussing the study, Clinical Utility of Maternal TORCH Screening in Fetal Growth Restriction, a retrospective 2-center study published in 2024 in RANZCOG. We'll be examining the findings of the study and the practical advice clinicians can take from the results. I'm your host, Dr Nisha Khot. I'm an obstetrician and gynecologist based in Melbourne and the president of RANZCOG. Joining me today are two of the authors of this study, Professor Lisa Hui and Associate Professor Natasha Holmes. Would you both like to tell us a little bit about yourselves?
Hey, hi Nisha. Thank you for having us here. My name's Lisa Hui. I'm a maternal fetal medicine specialist. I work at the Mercy Hospital for Women and the Northern Hospital in Melbourne, and I'm an academic at the University of Melbourne and the Murdoch Children's Research Institute.
I'm Natasha Holmes. I am an infectious diseases physician, and I work at the Austin Hospital and also at the Mercy Hospital for Women in their perinatal infectious diseases clinic, and I also am an academic at the University of Melbourne.
Thanks very much. Before we begin, I'd like to invite you to declare any conflicts of interest.
I have none to declare.
I have nothing to declare.
Excellent. Lisa, let's start with what instigated this research paper. TORCH screening is still commonly ordered. I know that in my clinic, it gets ordered very often when fetal growth restriction is diagnosed. Why did you feel that this practice needed examination?
As you said, TORCH screening is commonly ordered in clinical practice, and as the obstetrician in the perinatal infectious diseases clinic, I often see women referred after a positive result. What concerns me most is that these tests are being ordered frequently, but clinicians are not quite understanding what it's telling them and more importantly, what it can't tell them. So I think it represents a lot of waste and perhaps some reflex ordering rather than some considered selective investigation of fetal findings.
Couldn't agree with you more. I think we just reflexly say TORCH when we don't mean all of the things, and perhaps we don't realize what we're talking about or meaning when we order those tests. Now, not all fetal growth restriction is the same. Can you explain why the timing of fetal growth restriction matters?
We broadly think of fetal growth restriction as kind of falling into one of two groups, either early onset fetal growth restriction, which is onset or recognition before 32 weeks gestation. That is the less common of the types of growth restriction, but it is the more likely to be severe, result in preterm birth, and have an underlying condition such as a congenital infection or a fetal genetic condition. The vast majority of fetal growth restriction occurs late in pregnancy from 32 weeks onwards, and that's the group where investigation for perinatal infections with TORCH serology has very low value. Unfortunately, that's also the group where it seems to be most commonly ordered, and so that was the impetus for us doing this audit to see what the actual utility of these tests were.
Natasha, what did the study find in real-world practice?
Yeah, so as you mentioned earlier, this was a 2-centre Australian study of 718 pregnancies where TORCH testing was ordered in pregnancy. And in this setting, TORCH only included the diseases that you've just mentioned earlier, toxoplasmosis, rubella, CMV and HSV. In other settings, they may include syphilis or HIV, but this was not included as part of this study. And we excluded TORCH screens that were requested for pregnancy losses or if they were ordered postpartum. We found that actually over 70% of TORCH screens were ordered for isolated fetal growth restriction. That is, there were no other congenital anomalies found on imaging, and that most occurred after 24 weeks gestation. And in fact, the median gestational age was 29 plus 5 weeks, so very late in pregnancy, and almost half were ordered at 32 weeks or later.
We found that the clinical utility, or the rate of us actually confirming a congenital infection, was extremely low. Over 500 tests that were done for isolated fetal growth restriction, none actually returned a result that led to a diagnosis of congenital infection. We did find that in this 2-centre study, there were 2 cases of confirmed congenital infection. Both of these babies were born to women who'd been investigated for a clinical illness in pregnancy. So there was a clinical suspicion, fever, lymphadenopathy, very typical viral symptoms that led to the investigation and the testing. It really supports what other international guidelines are now saying, and that there's very low value in a routine TORCH screen for late onset fetal growth restriction.
Lisa, do you want to talk us through some of these international guidelines?
Yes, the one that was the most timely came out several years ago. That was the Society for Maternal Fetal Medicine. That's the American society. They updated their fetal growth restriction guideline, and they now recommend against doing maternal serology for toxoplasmosis, herpes and rubella in 3rd trimester. Congenital CMV is a consideration in some situations, and if you're seriously considering that as a potential cause for growth restriction, then the best test is actually an amniocentesis. But congenital CMV is usually accompanied by other ultrasound findings, not just a baby that's small for gestational age.
Lisa, this isn't the first time you've looked at this question. What did the broader evidence show?
Yes, we performed a systematic review prior to this audit, and we found when combining all the published literature, the value of a TORCH panel was very low. There were no confirmed cases of congenital toxoplasmosis, rubella or herpes simplex in the published data. Only congenital CMV was confirmed, and at a very low rate that would be consistent with actually the background birth prevalence of congenital CMV.
AFOG is headed down under. The 2026 Asia Oceanic Congress will be hosted by RANZCOG from the 12th to 15th October on Gadigal Country, Sydney, focusing on the theme Equivolution, Equity and Sustainability in Women's Health. The programme will cover topics such as environmental sustainability, equity in education and leadership, as well as equitable healthcare for women of all backgrounds. This is your opportunity to be a part of our region's largest O&G event. Connect with international experts in the field and learn about innovative research from across Asia and Oceania. And don't forget to soak up Sydney's stunning nature, food and culture. Early bird registration is now open until June 2026. Book your spot today to get the best prices. Visit aofog2026.com to learn more.
Natasha, many clinicians feel that TORCH screening is reassuring for patients. Is that actually true?
If we focus on the interpretation of serology results, you can really only rule out a TORCH infection such as CMV or toxoplasmosis if a woman is both IgG negative and IgM negative. And this result means that she's never been infected, and so therefore congenital infection is impossible. And so it's helpful, obviously, to summarise that IgG negative and IgM negative can be helpful to rule out infection. But that's not the most common scenario that we consider.
Lisa, what happens when we actually get a different result?
Yeah, the most common result is positive IgG and negative IgM. And for most people, they interpret that as reassuring, showing and interpret it as evidence of no maternal infection during pregnancy. However, it doesn't rule out primary infection in early pregnancy, because by the time you do the test, say in the 3rd trimester, that IgM, which is typically associated with the early phase of infection, might have disappeared already. So it actually doesn't exclude maternal infection in 1st trimester.
Just as an added note, in pregnancy at least, IgM is also a little bit challenging to interpret because there can be false positive results, and that also adds to the cascade of testing and maternal anxiety. And a positive IgM may also, even if it's true, may last for many weeks or even months beyond the original infection if it has indeed occurred. So it's a little bit unreliable to use it as a guide to time onset of infection if it has occurred.
So what we're essentially saying is that there is a lot of waste in doing what we traditionally call a full torch screen. Could you break down some of that waste, Natasha?
Yeah, well, if we think about some of the components of what the torch screening actually diagnoses, the first one that I might approach is HSV or herpes simplex. We know that if we consider that intrauterine fetal HSV infection is actually exceedingly rare, so less than 5% of all HSV infections. And when it does occur, it's associated with very severe central nervous system abnormalities and not just isolated fetal growth restriction, which is what we're discussing here. And we know that the majority of neonatal HSV infection is actually intrapartum, and a little bit is obviously postnatal. So maternal HSV serology in late pregnancy really does not diagnose the fetus at all and guide management.
And how about rubella serology, Lisa?
Yeah, what we found was that people are ordering rubella serology, even though we routinely screen all pregnant women at their first antenatal visit. And because people think of the acronym TORCH as an actual test, which it isn't, it's a combination of tests, the rubella is getting ordered on women with demonstrated immunity. So over 80% of the women who had rubella ordered in our audit already had documented evidence of prior immunity from their booking bloods. So that's like an easy place to save money.
The study acknowledges the Choosing Wisely campaign, which aims to reduce unnecessary investigations, treatments, and procedures in healthcare. In what ways is torch screening a Choosing Wisely issue, and what are the broader consequences of continuing to do this torch screening?
We did a very crude calculation of the costs of the serology performed at these two hospitals, and we found that over $64,000 worth of pathology was spent on these investigations with very, very low yield. The two situations where it was clinically useful was where there was a clinical indication for testing based on maternal symptoms. So that's just the cost of the pathology. It doesn't include the downstream costs that arise when you get a false positive result or difficulty interpreting a result.
And all the anxiety that goes with being told you have a result that may or may not have any significance would be huge for women who are already grappling with a diagnosis of fetal growth restriction and wondering, what's going on with their pregnancy, and then an added layer of having something like this to consider. To wrap up, some practical take-home messages from both of you, please, regarding torch screening.
The message from me is that don't order a torch panel for isolated late-onset fetal growth restriction. Congenital infection can cause fetal growth restriction, but it's usually not late-onset fetal growth restriction. And to make a true diagnosis, you actually need an amniocentesis.
Similar to what Lisa was saying, we really should reserve infection testing for early onset fetal growth restriction, or if there are specific additional ultrasound abnormalities. And also if there are maternal symptoms or other clinical abnormalities, and this can sometimes be challenging because the symptoms may be mild or non-specific, but if infection testing is required, it really should be targeted and not automatic panel-based, which is where we're trying to improve wastage with medical testing.
Thanks very much to both of you. You can access the full RANZCOG paper, Clinical Utility of Maternal Torch Screening in Fetal Growth Restriction, a retrospective 2-center study, via the link in the show notes. If you enjoyed this episode, please rate, review, subscribe, and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more essential conversations on Talking O&G.